Now we go below the clavicle. The next speaker is Dr. Sandeep Diwan from Miraz. He specializes in ultrasound guided blocks in neonates. And he is on the faculty of Tysora and NWS. He has just returned from Rome last night, I think. Dr. Sandeep Diwan.
Morning, everybody. Yeah, we are all self-invited speakers, so I don't have to thank anybody. But I should thank you all for coming over here and attending this and making it a big event. And this is going to be our emblem throughout. So we are going to go below the clavicle. Now you know that there are three trunks, divisions trunks, and they come below the clavicle and then they spread below the clavicle to form the cords and then the peripheral nerves in the axilla. So that is how we are going to see. And the lecture will end the moment the time ends. Okay, you took a moment of me also. This is a coracoid block, which is a safe technique, and it was described by Wiffler in 1983. And the anatomy is very complex and variable. You should be very well versed with the anatomy because this is very important when you perform these nerve blocks, visit the cadaveric dissections, visit anatomy halls, perform cadaveric dissections as well. Inconsistency of cord placements infraclavicular is a major problem, and there can be dual contribution to the median nerve. This is the clavicle. Now this is the pectoralis major, which has been reflected on this side. This is the subclavian vein. This is the artery, and you can see how close are the trunks. I mean the cords, which are very, very, very closely placed. This is the lateral cord, which you can see. So the moment the needle comes, it hits the lateral cord. This is the musculocutaneous response that you're going to get the biceps flexion. The moment you reorient your needle, you can either be in touch with the median nerve or you can go in for the posterior cord, which is very deeply placed. That is why the posterior cord placement of the needle tip is quite difficult in most of the times. Now this is a sagittal section. You can see this is the pectoralis major, this is the pectoralis minor. The needle is going to come two pops, pectoralis major, pectoralis minor, and then it hits the lateral cord first. This is 6 is the lateral cord, this is the posterior cord, that is the medial cord, and this is the subclavian artery and the vein. So you know how close is the needle tip, close to the subclavian artery as well as it is close to the nerve. So there is a very small distance and a very small error might lead to some of the complications, even in infraclavicular block, though it seems to be very safe. Now this is a coronal section, MRI. As you go from anteriorly, pectoralis major, pectoralis minor, you come across the musculocutaneous nerve. That is why again you get this response. That is why you have to reorient your needle towards the posterior cord, which gives of the radial nerve. The radial nerve is the end branch of the posterior cord. And then sometimes you can get axillary nerve. You can get the deltoid contraction sometimes in infraclavicular. That is because you are stimulating the axillary, which is also comes from the posterior cord. Now, it's not quite easy to have a infraclavicular block is because this is the artery and these are the placements of the nerve. This is the posterior cord, that is the lateral cord, these are the medial cord. These are the various placements that the Sauter and colleagues have found in one of the, in volunteers, in healthy volunteers, when they have placed ultrasound in the infraclavicular area. But it's relatively easy anatomical landmarks. Palpate the coracoid process, 2 centimeters medial, 2 centimeter inferior. Pushing the needle vertically, one pop pectoralis major, second pop pectoralis minor, you are on the lateral cord. So that's why it is supposed to be tailored to perform. Now, one of the things is that you have to forget the lateral cord placement, you have to forget the other branches of the posterior and middle cord, and you have to concentrate on the radial, which is extension, or median, which is flexion. There are a lot of approaches, as you can see, but we are going to choose one of the approaches, that is Wilson's approach, which is 2 centimeters caudal and medial to the coracoid process, and the needle is absolutely perpendicular. So this is the approach. Coracoid process, 2 centimeters medial, inferior, this is the clavicle. One thing to be kept in mind is that the brachial plexus, it passes through one line, is called as a brachial line. C6 tubercle, palpate C6 tubercle, midpoint of clavicle, and the axillary artery. If you draw a line from the C6 to the subclavian artery, this is the brachial line. On this, you can go from wherever you want. That is these are the various approaches. The various approaches are to increase the efficiency and decrease the complications. That is the role of the various approaches. That is how you place the needle. And that is how you reorient your needles. This is the artery. These are some of the trunks. And this is below the clavicle. And that is how you give the drug. So coming to multi-neurostimulation basis, this is one of the video clips which should run, I think, yes. Now you can see the needle is placed. I'm not holding the needle is supposed to be in the sheath. I could get some of the lateral cord response, that is the biceps, and then you can see the extension of the fingers now. Can you see that? So that is the posterior cord neurostimulation. And if you see that when you have left the needle on itself, and the needle is tip is eliciting contractions, it means that the needle tip is in the sheath. That means the sheath is holding the tip if you are leaving the needle by itself. That means you are precisely placing the needle tip absolutely inside the sheath. And you can see slight shifting of the gear. It helps in increasing the contractions. This is the precise placement at 0.3 milliamperes. If you're going to get this, you can straight away inject 30 ml of drug. I inject 1.5% xalokin and 0.5% 5% bupivacaine, depending upon the duration of the case. If it's short, more of xalokin. If it's long, more of bupivacaine. This is another elicitation. In this, you could see the fingers being, there is extension of this. Sometimes there could be flexion of this. So this is multi-neurostimulation. I'm having a median as well as a posterior cord stimulation. In the previous slide, I had a lateral as well as a posterior cord stimulation. So you can have a multiple of this. You can have a plethora of neurostimulation in this infraclavicular. It depends upon where you're putting the needle tip. In between the median, in between the posterior and the lateral, in between the medial or the posterior cords. One thing to be kept in mind, the forearm is always comfortable on the patient's abdomen. Now this is one which has to be done in infraclavicular block, and this is because when you, in adduction, the cords are very close to each other. When you keep in adduction, the cords will be very close to each other, while in abduction, they're going to move away from each other. And that's why, and most of the patients with forearm fractures, they tend to keep their forearm on the abdomen. And this is a good part for us. Now, in one of the studies, I tried to inject the contrast whenever I got a neurostimulation. So this was initially a lateral cord stimulation, then a posterior cord, and then I could get a medial cord. This was only for study sake. At the end, when I got a medial cord response, I gave in the local anesthetic. So the failure rates are more with the medial and the lateral cord, and you go in for the posterior cord response. That is for sure in all infraclavicular blocks. Now this could be another interesting slide over here. You can see I had only flexion and extension of the thumb. I could not see the other because they had it was covered in the splint. So I could elicit only the flexion and extension, which was I could see both at the same time. So it could be a posterior cord and it could be a part of the medial cord because that's where the needle was positioned. And then I gave in a local anesthetic injection, and once you give that, it disappears. Now watch this. This should not be done. Whenever you do that, you should not leave the patient unattended because he doesn't know that the limb is anesthetized. So this should not be done at any cost. I was about to go to near the patient, but these things can happen really. So you have to be very, very careful when you anesthetize these limbs. I have done many contrast studies for under CT scan. This is the clavicle, that is the coracoid process, that is the whole of the scapula on the other side, and this is the thoracic wall. So the boundaries are in between just below the clavicle, the thoracic wall, and you have some muscles on this side. So this is the contrast which is injected over there. Some of the surgeries like this on the elbow can be done, but you have to be sure that you have the patient totally anesthetized just before you go in the block, because you're going to keep the patient awake all the time. And this is again some of the surgeries on the elbow. So most of the surgeries on the elbow in the lateral position can be done with these infraclavicular blocks. And the dose is 1.5% xalokin and 0.5% bupivacaine, these concentrations and volumes. And I usually put in a catheter for continuous infusions. So do we really require a supraclavicular block? Because most of the times I found the contrast, this is the posterior cord and this is the medial cord. So most of the times I've seen the contrast going just below the clavicle and in the supraclavicular area. And sometimes the contrast even extended into the interscalene. So that is the needle, and this is the contrast going in the supraclavicular area, and it goes sometimes right up to the level of the roots. So you can uniquely see in some of these cases that when you give a contrast, the extension of infraclavicular into the supraclavicular areas. Continuous infraclavicular, I usually go for polytrauma of these upper limbs like this, where they have multiple fractures of the upper limb. And this is a good placement of the catheter over there for some of the tumors, which can be excised under an epidural and a continuous infraclavicular. That is a continuous interscalene. This is infraclavicular, continuous infraclavicular. These are the two in the same patient, continuous interscalene and continuous infraclavicular. And this is the infusion pump, which at the end we keep 0.2% ropivacaine with 75 mics of clonidine and with 50 milligrams of tramadol. And it is infused at a rate of 5 ml per hour. Patient does not have an insensate limb and can move the fingers as per her desire. So thank you very much for your kind attention. And this is the